Okay, so we're just going to talk through some of the more difficult airway decisions and how I want you to approach them and be thoughtful as you approach difficult airway cases. So I want you to think of, I'm going to give you 3-4 questions that I want you to think for every case. The first thing that I want you to think about is, do I have an adequate minute volume for any patient that you walk up to? So let's just put that in a situation. You walk up, excuse me. You walk up, you find a COPD patient that's in respiratory failure. They're not interacting with you as you approach. You find that they have, so they have an altered level of consciousness. Let's say they're responsive to loud verbal stimuli. You find that their airway is patent and they are managing secretions. And then when you turn your attention to breathing, you find, you know what, they have a really fast respiratory rate, let's say 50, and it's a really shallow, not adequate. So your response is going to be, they don't have adequate minute volume, is fix it, right? So if you have to fix it, typically we'd fix that with a bag valve mask, right? We'd anticipate we put a bag valve mask on that patient, and we find that they have, they get chest rise and fall, typically with that. If we had difficulty with the bag valve mask, our next step would be to troubleshoot that bag valve mask. So my suggestion to you would be to sit them up greater than 20%. If they're not, 2 NPAs, an OPA, and two hands on the mask, so 2-person bag valve mask, right? To get chest rise and fall. That will fix 99.99999% of patients, is that bag valve mask. Obviously, take their, if I'm thinking medical, not traumas. We're not talking about C-spine right now as far as sitting them up. So we fix minute volume. The moment we fix minute volume, we're back to our cozy, wonderful land where we have time. So I'd go level of consciousness, airway, breathing, get stuck in breathing for a little bit, fix breathing with, let's say, 2 NPAs and an OPA, and sitting them up makes it doable with one person. Then I would go ahead and then go feel a pulse, see what my pulse is, and then I would do a physical assessment. I'd ask what happened today with OPQRST. I'd ask what happened in the past with ample. I'd make a differential diagnosis, and I would decide whether or not to intubate. Okay? If intubation was indicated, right? If they're not protecting their airway, don't have the tube's not open, there's something in the tube, they're failing to have proper ventilation, which our patient is currently in respiratory failure, then they meet the indication. And the last thing that I like to think of is predicted clinical course. I want you to think about, what does this patient really need, right? What would you want if you were laying on the stretcher? And that's different based on the situation. So a COPD patient, let's say we're an emphysema patient, thin, frail, older gentleman that's in respiratory failure, that's currently able to ventilate with bag valve mask. We decide they're in COPD. We say, what does really need to happen? Well, they're going to get intubated. They're going to go to an ICU. They're going to probably figure out if they got an infection. They may give them some antibiotics. They'll give them some supportive care, and then see if they kind of overcome whatever issue has led to respiratory failure today. And then they'll try to wean them off the tube, and then they'll come into the hospital. But it's a very different situation, can you see, than if I had a patient, let's say I have a 60-year-old male that has had complaint of chest pain today, big chest pain, suddenly had pulmonary edema, and then became short of breath. And I came in and I gave positive pressure ventilation. Maybe I put a PEEP valve on, which helped his pulmonary edema, but he's in respiratory failure. We do a quick physical assessment. We get a set of vitals, and we go, intubation would be nice. And we go, what does this patient really need? You go, well, we happen to throw a 12 lead on. We saw massive ST elevation. We don't have thrombolytics in our service. So if that was me, I want you to take me to thrombolytics, or even better, take me to the cath lab, right? But do, like, intubating, if you have the tube open and you're able to breathe for me, that could wait. Doesn't mean it's not indicated, it's just not a priority, comparative speaking. Does that make sense? So I just say, what does this patient really need? If I was laying on that stretcher, what would be the best thing for me? What would you want? So the first question is, do I have adequate minute volume? If you don't have adequate minute volume, we're going to fix it. Let's think about another difficult situation as far as minute volume. Let's say get called to a hockey rink, right? Some kid has got kicked in the throat with a skate, somehow got under the neck guard or wasn't wearing it or whatever. They're pretty stringent about wearing those things today. And you go, wow, it's really terrible. You're like, it is really terrible. And you arrive and you go, wow, this is really bad. You go, altered level of consciousness, in completely cyanotic, lips blue, periphery blue, barely move, is tachypnic breathing, but barely moving any air. And you go, crap, this is bad, right? I don't have minute volume. This kid's going to die if we don't fix this. So I'm going to thoughtfully think through whatever I think could possibly work. I think I absolutely would try two-person bag valve mask. Might not, if they crush whatever's in their neck, there could be a variety of injuries, right? It may or may not work. I would try two-person bag valve mask. Then I would think, I would justify through and say, do I think extraglottic could work? Right, if they got a hole in their throat and when I'm bagging, bubbles are coming out, extraglottic device is just going to make more bubbles. It's not going to do anything for them, right? Right? You might be intubation even. You're saying, well, intubation might be very difficult past the tube given all that trauma, and I have a hole right here. Maybe I'm just going to end up putting a tube in that and do a surgical airway. They've already done the cut for me. It depends on the situation, but you have to justify from least invasive to most invasive whatever you need to do to get minute volume that's compatible with life. The moment you have minute volume compatible for life is the moment you have something to lose. Does it make sense that we don't want you to assess difficult airway characteristics, whatever you guys are using Ron Wall's algorithms, the other classes right now, the on-site classes using George Kovacs. Both wonderful books, both great smart minds. Say the same thing in their acronyms for what to assess, right? You're using Lemon, Moans, Rods, and SMART. They're all very similar. But you know that I've said fear upper airway obstruction. People, obese patients, third trimester pregnancy, any evidence of upper airway edema, so hoarse voice, difficulty swallowing with dyspnea, stridor. You know those people, I should fear that, right? So so we just need to be aware as we're going through our airway assessments. Do I have difficulty is the next question I want to ask. So the first question you get in is, do I have minute volume that's adequate for life? If you do, then we do airway assessments. If you don't, then you don't do airway assessments because you're already cyanotic and blue. You're saying, I have nothing to lose. They're already not breathing adequate for life. So in a foreign body airway obstruction, it makes sense that we come in, we go altered level of consciousness, maybe we check for a pulse, we find a pulse, maybe not, depends on the situation, how long they've been down. We start chest compressions. We go and grab our laryngoscope, an appropriate size tube, McGill forceps, maybe grab our surgical airway kit while we're grabbing things open. We come over and we go right down. And you say, well, we didn't try bag valve. Well, we would have tried bag valve mask initially in confirming. We tried two-person bag valve mask, don't get chest rise and fall. Does it make sense that I'm not going to try an extraglottic device if I say the words foreign body airway obstruction? Because the obstruction's down there and I'm trying to open a tube up here. Doesn't make any sense, right? So you might not use your extraglottic device. You go right to your laryngoscope and try picking things out. Maybe you can't pick it out, right? Maybe you can't intubate and you go right to surgical airway because you can't pick it out after a reasonable amount of time. Because we know you can only hold your breath so long and then you become brain dead, right? So you just rapidly do, at the moment you say, I have inadequate minute volume for life, then you rapidly address whatever problem you have. You don't do airway assessments at that point, which kind of intuitively makes sense, because you have nothing to lose at that point. They're not breathing, they don't have an airway. But the moment you have something to lose, then airway assessments are important. I think any time that I could do airway assessments, that's informative information at any time. But I'm just saying, if you have limited resources, which we often do, and trying to do multiple things, you might not have time to do that. Does that make sense? So if you have adequate minute volume, the moment you have adequate minute volume, we reset back into our nice, happy place, and we can do our physical assessment appropriate for that patient, get our vital signs, find out what happened in the past, OPQRST, today and in the past with ample, and then we make a differential diagnosis and come up with a working diagnosis and formulate a treatment plan for that. And if that treatment plan includes intubation, we need to ask, is this what's best for the patient? Am I preventing what they really need? We agree that intubation's necessary, but you can see in a big thoracic trauma or something that we have somebody that has maybe in respiratory failure needed to be bagged. Maybe the best thing is to get to the trauma center, right? They meet the indication. So you find big services that will have things like, we're not RSIing patients unless they're 20 minutes away in those situations. And that makes sense to me, that we want to get them to what they really need. We don't want to delay definitive care. Think about, if I'm on that stretcher, what do you want to do for me? In some traumas, I want you to intubate me. If you think I can't ventilate you, then my gracious, you need to get my airway or I'm going to die, right? I'd like to see my grandchildren, right? So please get me there. So then, so after you've decided, so first question is, do I have adequate minute volume? The next question is, do I have difficulty? If you don't have difficulty, then we can intubate, right? If you do have difficulty, that's where some of the muddy waters come out. But the next question after, you recognize difficulty. So let's put some questions. So let's just start off with like a morbidly obese patient. That we walk in, we have a patient that's COPD, respiratory failure, and we put a bag valve mask on. It's a little bit difficult. We sit them up a bit, and we put some NPAs in. They won't take an OPA, and that seems to do it. We seem to get adequate minute volume. We do a physical assessment. We find out what happened today and what happened in the past through OPQRST and ample. We make a differential diagnosis. We make a working diagnosis, and we create a treatment plan. In that treatment plan, I say, hey, I'd like to intubate this patient. And I go, intubation. Okay, well, it's indicated what does the patient really need. It's indicated, patient really needs. It seems to align. I'm not delaying any definitive care. And then I go, well, is it difficult? And I go, wow, looks difficult. Right? Right all the way through. My bag valve mask, extragalactic device, and intubation are all going to be more difficult. And I go, my next question is, do I have time? If I have time, then I'm going to take them to the hospital. Does that make sense? We're just going to go, great, currently bagging you. You currently have time. Lovely. Let's take them to hospital. That makes sense. If that was me, that's what I want you to do with me. Is don't kill me trying to intubate me in a situation where you didn't have to. Take me off to the anesthesiologist with lots of cameras and lots of hands. Please be involved in that process when you get to the hospital. The more you can be around difficult airways, the better. The easier this is going to be for you. But I don't take that on by yourself. What if, let's say, another situation. Let's say I just came out of a house fire, right? You happen to be really close, fire department called, you're 3 minutes away, you arrive on scene. I'm relatively pissed off that I was in a house fire and that I got burned. But you notice that I have a hoarse voice. And I seem to be a little dyspneic. I report feeling short of breath. And you go, well, okay, airway's good, have adequate minute volume now, high flow oxygen. Quick physical assessment. Do OPQRST and ample. Differential diagnosis seems straightforward. Burnt your throat. I know that I'd like to have you intubated, but I know that you have some I see some signs and symptoms of obstruction. And I know that interferes with bag valve masks. I remember Matthew telling me to fear upper airway obstruction, that if you give people drugs that decrease their level of consciousness, you might lose their airway tone and then not be able to ventilate them with a bag valve mask. That'll make the situation worse. So you know that. You go, wow, that's difficult. And then you said, okay, well, I knew minute volume now, intubation is indicated. I knew I was supposed to ask if there was difficulty. And then I was supposed to ask, do I have time? And depending on your situation, how sick your patient, let's say they don't seem that sick right now. They're tachypneic, maybe a little tachycardic. I would love to have this patient intubated. But what I think I'd like you to do for me is I'd love you to put me in the ambulance, start heading towards the definitive care that comes with a trauma center. As you're going, I think that you would continue, provide high flow oxygen, and you're going to set up all your intubation equipment that you may need, so your entire bar is set up. And then you might turn and go, you know what, let's start trying to give you a little bit of topical anesthetic, that we might be able to try awake intubation. Or even if this isn't me that's doing this, I'm starting this process for the lovely emergency physician that's going to take care of this patient when I get there and say, you know what, I've started trying to work on getting awake intubation. So if you have 5% ointment they tolerate, try to paint their tongue, spray with the lidocaine, and see where you get. Don't delay getting to hospital. And this is all about how much time I have. You go, I think I have time. I think I have time to get to hospital. But I think this is going to be difficult for someone else, and it may become difficult for me. And I know that I'd love to have this patient intubated. If I had them intubated, if someone I could wave a magic wand and say, you're intubated, I'd do it. It's just the getting there that's the problem, right? So I know that I want them intubated. It's just, I'm not sure that I can do that. So I don't think we sedate them, go chase them with RSI, or facilitate intubation if you're in a system that doesn't have paralytics. I think we take them to hospital. Don't delay getting to that person that might be better at this if you think getting there. And I think that serves well. If you're sitting in the stretcher, you say, what do you want done for you? If you have time, I think you're lovely. I'm really passionate about paramedics doing intubation. But I'd love for you to take me to an anesthesiologist who manages difficult airways often, who's been intubating people for decades in an OR, right? That has lots of tools and lots of hands available. That's who I want, or a really great trained emergency physician that's got lots of cameras available to them, lots of hands. That's who I want to mess with my airway in that situation. Now let's go to that situation again. Let's say I came out, but this time I was in a little longer. This time I come out, and you walk up to me and you go, airway breathing, and you go, I think that's adequate. I think he has adequate minute volume right now. It's just barely, but I think it's adequate. High flow oxygen goes on. Quick physical assessment, 30-second rapid trauma assessment. You go, okay, differential, you burnt your throat. Treatment, get him to a trauma surgeon, and we need to secure that airway. And you go, okay, well, next is difficulty. Assess for difficulties. Lemon, Moans, Rod Smart, or the other version. Boots and Moods. And Dart are the alternate. George Kovacs say the exact same thing. So you go through and you say, that's difficult. I know to fear upper airway obstruction. I know that this gets worse. And then your next question is, do I have time? If I have time, then take me to hospital. If you go and if you go and you look at me and you go, wow, that's sick. I'm 30 minutes away from a trauma center. If I was betting their life, I would bet they're going to be in respiratory failure before I get to hospital. And I'd like to give them the best chance for life. So this is going to mean that we're going to have to go into this really difficult airway. And I want to emphasize that this is a really, really, really rare situation. But you need to be convinced that the patient is at risk of dying before they arrive to the hospital. If I'm here, like you can see that proximity changes. If I'm 3 minutes away from a trauma center, and I'm like, I think you're going to die, you're going to see me scoop you up. I want you to scoop me up incredibly quickly, with high flow gas running and run me to the surgeon, right? Who puts trachs in every week, right? Feels really comfortable with it. Where my hands are going to be like this with a scalpel, right? So I've done it cadavers, I've done it on pigs, I've not done it on anyone live. Even the people that are used to doing this are going to find this an incredibly stressful event with a blue person in front of them. This is a very difficult situation and incredibly rare. But if you say, I think they're going to die, if you're unsure about that decision, then by all means, talk to the physician. Tell them what you're seeing. Ask them their opinion. And get their opinion of whether or not you should act at this point. Tell them how far away you are. And they'll make a similar decision for yourself. Okay? So if you say, wow, I think they're going to die, if the physician says, yeah, I think you need to deal with this now, or they're going to be in cardiac arrest, then you're going to have to address it. And that means that we're going to prepare all of our equipment. We're going to use RSI if we're in a system that has RSI, and if not, we'll use whatever facilitated intubation that is utilized. And you're going to try to capture that airway. And you're going to know in your mind a good decision to make is the decision that I'm likely to end up in a surgical airway. Can you see that that's an easier transition, that you don't want to get stuck at the airway and being like, crap, I gave this patient drugs, I can't get them tubed. The moment you give me drugs in that difficult airway, you need to be thoroughly convinced. Picture when it goes bad, that it might go bad. Because we're taking that risk that it might go bad. Poor Matthew seemed like a nice guy. I heard he had lovely kids, nice wife. I don't know how she put up with him. Anyhow, and he came out of the fire. It was a really shitty experience, whatever happened. Came out, and he was really short of breath. And he was cyanotic, right? Or, well, maybe not quite cyanotic. Well, we're saying he had minute volume at first. We're 20 minutes away from a trauma center. You go, I know when I hit my finger with a hammer, it doesn't take long to swell. Right? I'm just assuming that when I burn my finger or I burn my trachea, it's not going to take long to swell, right? And I go, wow, I don't have much time. And he's stridorous right now, and it doesn't look good. And I went, you know what? And I said, I think you have a chance of dying. I think you're actually I'm convinced you're going to die if I don't do something right now. I could wait for 5 minutes and watch you die and then cut your throat, but I think it would be better for you to actually put you to sleep and try to do this beforehand. And I went in. I went in with intubation, gave my best attempt, did everything perfect, failed at it. Couldn't see anything. It was black. I didn't have a camera. And I went, and then I went, crap. And we threw a King LT in, and we're trying to bag through it. We're getting very minimal chest rise. I decided to do a surgical airway. I screwed it up. I didn't get the surgical airway, and he died. And you're going to have to sleep with that. And how you're going to sleep with that very well is that you're going to say, is the situation. That's the situation. You have to say, I'm okay with accepting failure because they're going to die. Does that make sense? But it's a big decision. So I'd tell you to lean into your medical control physicians. If you're in this situation, and this is an incredibly rare event. Royal College physician, emergency trained physicians that may not have dealt with a failed airway. I mean, that's a big residency, and they may not have dealt with that. This is an incredibly rare event that most of you will not see in your entire career. So you just need to be confident. It's good to think through. But you need to also realize that this is not the norm, right? So this is furthest away thing that as far as the norm. But it's useful for you to be prepared. But if you choose to act on that airway, if you hesitate, then ask someone, call somebody and get their opinion. I think it's a useful thing. And then you're going to have to act decisively. And you just need to be comfortable that if I do this, that I feel convinced that if I don't do this, you're going to be blue and dead anyways. So I'm going to give you the best shot at life possible. So the questions I want you to think through is, do I have adequate minute volume? You could see how it would be easier for you to make this decision. Thankfully, most of our patients, it would be easier to make this decision if I'm already blue, right? You say, cut my throat, because I don't feel like I caused this. I agree completely. I don't want to feel like, if I think that even remotely that I think, hey, I think you might not, I think we might have to, you might not force my hand, your disease or injury might not force my hand to this, then I'll avoid this at all cost. But you can see that if I had walked in and I saw inadequate minute volume, that's an easier decision to cut their throat because I didn't do it in any way. I'm not saying cut their throat. I'm just saying tried 2-person bag valve mask, tried extraglottic if it was appropriate, tried intubation if it was appropriate if I had a chance. I mean, sometimes we'll have people with massive facial injuries, right? That are, you mean, if you're like injured with guns and whatnot and like missing part of their face, right? If you walk in and you're having trouble landmarking where their tongue is, intubation will probably be very difficult if you can't see any bubbles coming out, right? So if you're having trouble, you might go bag valve mask, that's not going to work. Extraglottic, that's not going to be helpful. Intubation, I can't see anything, right? There's a situation that you could run into that surgical airway is the only intervention. But that's easier when they're already cyanotic and just peri-arrest, right? Like almost in cardiac arrest, if not in cardiac arrest. That's an easier decision because it's already progressed further. But it is far better, I would much rather you, for me, I would much rather you, if you're absolutely convinced he's going to go into cardiac arrest in the next 5 minutes and I'm 30 minutes away from help, I'd much rather you try then before letting me go into cardiac arrest and then having to go to a surgical airway. So the questions are, do I have adequate minute volume? If you don't have adequate minute volume, fix it. If you don't, the moment you have minute volume, you have something to lose. Finish your assessment. Figure out what's going on today. If it's if like a medical patient, figure history, OPQRST, and ample. Make a differential. At least narrow down what you think is causing the problem today. Think about what does the patient really need. What is the definitive care? Am I delaying it? So if it's indicated and not delaying definitive care, then think about is it difficult? If it's difficult, then think about, do I have time? If you have all the time in the world to go to the hospital, sometime, maybe awake intubation fits into there. Don't delay doing awake intubation on scene. Think that's a transport while doing awake intubation. And if you have no time, gonna die, then you're gonna have to make that decision. And that's gonna be a very challenging one. And I will encourage you, call for help early. Like any crisis, call for help early. And get on the phone with somebody if help's a long way away. And say, hey, this is the situation I'm into. What do you think I should do? This is what I'm thinking. I'm not wanting to tell them the fear. Like when you're calling in those situations, in crisis, say, this is what I'm wanting to do. This is what I'm afraid that may happen. What do you think I should do? This is what my capacity is. And you're going to have to make the decision. And it's much easier with somebody else that will be able to be a little bit, hopefully their heart rate won't be quite as elevated. So I'd encourage you, if you have any hesitation, that if you're like, hey, I don't know if I should act on this is difficult, then call and ask. Okay? It's going to be a really difficult situation, and you're not likely to see it. It's incredibly rare. Most of our patients, we walk in, we go, inadequate minute volume, bag valve mask on their face, adequate minute volume. We're back to normal. Everything's cool and chill as can be. We do our physical assessment, get vital signs, figure out what's happening today, make a treatment plan that makes sense, to think about intubation, just make sure that we're not delaying definitive care, and then decide whether it's difficult. And if it's difficult, usually we just take them to hospital because it's not going to deteriorate. So the deteriorating patient are the trauma, upper airway edema that's nasty, like really bad anaphylaxis or something, which is incredibly rare. Cool? You can pause, you can turn that off.